Do you suffer from moderate to severe plaque psoriasis?
You know, the commercials where somebody is suddenly hiking, smiling, and living their best life.
While the voice calmly lists 47 possible side effects, including death.
Yeah, today we're talking about that plaque psoriasis.
Real skin, real science, real confidence. With Dr. Zain Hussein. Welcome to
Skin Side
Out.
Welcome back, everyone, to another episode. I'm Dr. Zain with Courtney and Heather. And today we're going to be talking about plaque psoriasis from the inside out. We're going to be talking about what plaque psoriasis is, what the etiologies are, what the symptoms are, and also the treatments. So let's get right into it. Heather, what is plaque psoriasis?
So plaque psoriasis is a chronic inflammatory autoimmune condition. So in normal skin, our skin cells turn over once a month. In psoriasis, they turn over like within a few days. And so that dramatically thickens the skin and causes that plaque to form, and it's really thick and scaly and inflamed, and it's usually pretty itchy too.
You know, one of my favorite terms from residency, that silvery scale, mycaceous.
Yeah.
Thank you.
I'll be here all week.
Mycaceous. And, you know, I know that people describe it as an autoimmune condition, but is there really an allergen that there's an antibody to?
No. It's, we'll kind of get into this more when we talk about treatments, but we use different treatments to target that immune response. And that is what's kind of causing that turnover rate to happen so quickly.
That's just a minor point, but I think it's an important point.
Yeah.
It's not like a true autoimmune condition.
Yeah, because people say like, oh, I have an autoimmune condition, but it's different.
Yeah. It's a pro-inflammatory condition.
Yeah.
I tell everyone about my autoimmune condition, my psoriasis. I tell everyone, I have an autoimmune.
And your Ehlers-Danlos and what else? Self-diagnosed.
Your fibromyalgia.
We have a list, don't worry.
We literally do in our office. Courtney's medical history.
It gets longer every day.
Especially under the mental health category.
So rude, so nasty, and so rude. But it does affect the skin. It does affect the joints. Everyone has probably at this point heard of psoriatic arthritis. It can affect the nails and other body systems. There's been studies to show its influence on the cardiovascular system. So I think, you know, it does need to be taken seriously as more than just a skin rash.
And it is chronic. I mean, it will kind of wax and wane for a while, but even though it looks pretty dramatic, typically it's not contagious, so you don't have to worry about that.
Yeah. So what is the cause of psoriasis?
So I think it's a number of things. I think it can be like the dysfunction of the immune system, genetics. We often see people who have psoriasis do have a strong family history. And so from that immune standpoint, we see certain white blood cells, especially like T cells, become very overactive. And I guess that's what I kind of mean by that immunity dysregulation, almost, that creates the...
Yeah, I like that term.
Yeah, and then it causes that redness, the scaling, and the itching.
So let's talk about triggers for psoriasis. So what are some of those triggers that we see?
Stress. Big one.
Yeah, that is a big one. We see it with eczema a lot, but I think we see it with psoriasis more.
I agree.
Yeah.
Definitely some people notice in the winter, the cold, dry weather, again, skin trauma. So there's a Kepler's effect where if, let's say you're scratching the knee or something, it will become a little bit more thickened and bring out that scale.
So with the Kebner phenomenon.
But also, I think a huge one is smoking. I feel like there's a lot of psoriasis patients we see who are smokers and...
Or alcohol.
Heavy alcohol use, definitely. You just want to like shake them and be like, stop it. You know, especially the smoking.
Yeah.
Alcohol.
Even infections can lead to psoriasis, specifically strep infections. It has a strong correlation with gut psoriasis, especially in kids. So that's something we do see frequently.
And certain medications too. We've seen it with like beta blockers and certain mental health drugs.
Also with certain biologics can actually lead to psoriasis flares.
Yeah.
And then I do think that if you can identify the triggers, like with many skin conditions, avoiding it is probably the best option. But, sometimes these triggers are like, unavoidable as part of life. Yeah. All right. So what symptoms are we seeing with these psoriasis patients?
So the itch, but as far as the rash goes, usually it's pretty well defined, deep pink, maybe even like salmon-like color patches that get really scaly. Yeah. That's a very classic photo of psoriasis. And you can have it generalized like this, so pretty much everywhere on the body, but you can also have it in very classic areas, which are like on the backs of the elbows, on the fronts of the knees, like the top of the buttock area, belly button, scalp. Those are like kind of the tried and trues. You can also have a type of psoriasis called inverse psoriasis, where you get kind of like in the folds, so like in the underarms, like in the groin, maybe under the breasts. And then you mentioned guttate, which is these tiny little
raindrop-like.
Yeah, raindrop-like psoriasis. And they're still pretty scaly like that, but they're not as geometrical. And that's the one that typically flares after strep.
Yeah. And just like with eczema, we see a varying severity. So you can have just very limited, like a single plaque. And you can go all the way to erythroderma, where you're like head to toe covered in psoriasis, flaring, having systemic symptoms. And that is also a medical emergency. You need to be hospitalized and you need to be cooled down.
It can also affect the nails. So sometimes we'll see nail pitting, which it almost looks like if someone took a little ice pick into the nails and they disfigured the nail. So sometimes when you're going in for your appointment, if you have a rash or you think you have psoriasis, your dermatologist might go ahead and take a look at your nails and see if they're seeing any of that pitting.
Yeah.
That's a very classic sign that your joints could be involved too.
And in addition to pitting, we can see thickening of the nails and oil stains, so that yellowish kind of appearance to the nail. So these are all signs of psoriasis.
And like we've alluded to, you can have joint pain, so you can have psoriatic arthritis. You can get dactylitis, which is so much inflammation in the joints that you get kind of like sausage-like fingers, which Courtney has a lovely. So this is pretty classic.
The real sausage
Yes,
fingers.
this is a real dactylitis or sausage finger. But Courtney loves her movies.
Not to be confused with hot dog fingers.
Yes,
like in the Academy Award or the Oscar nominated movie, Everything Everywhere All at Once, aka Courtney's favorite movie. That's all I can
might have dactylitis.
Every time I hear sausage digits, this is what I think of. It's the hot dog fingers.
Yeah.
They're thick, uncomfortable, I'm sure.
It looks pretty, if the joints are involved and you have psoriatic arthritis, it looks pretty classic on x-ray. It's like it kind of looks like a pencil in a cup. Like your joint is kind of remodeled like this, and then the bone on top is kind of sitting in like a pencil in a cup. If I'm describing that well.
I remember having a boards exam question where they showed us the x-ray.
Yeah, it's very easy to.
Yeah.
A lot of times people with the psoriatic arthritis, it's more so in inactivity. So for example, most people with psoriatic arthritis, they'll feel more in the morning. Let's say when you've been kind of, laying down all night, not moving, not active, you get up in the morning and it's like taking a long time to really get settled into your body kind of feeling, where you're like, oh, I'm just so stiff, so sore. Sometimes like, if you're sitting in the same position. Today I was sitting in a crisscross position for 30 minutes.
But rheumatoid arthritis is similar too. Like your hands are very stiff in the morning.
And that raises a good point, where we co-manage a lot of these patients with rheumatology.
Yeah.
So our rheumatology colleagues are very good at, diagnosing, detecting, and treating psoriatic arthritis. And we often co-manage these patients. And many of the medications that we use to treat psoriasis also have protective effects and treat psoriatic arthritis, which is really nice. So I have had a lot of interesting cases that, I always get, rheumatology involved. Even if the patient doesn't say they necessarily have joint involvement, I always like getting an evaluation, because oftentimes with cutaneous or skin psoriasis, we see the skin manifestations first, and then oftentimes, like even by a decade later, you start seeing the psoriatic arthritis. So I like getting them plugged in, making sure that we don't see any joint damage, and helping to prevent that too.
And I think it's important to tell your doctor if you are experiencing, I think a lot of patients tend to dismiss symptoms like that. Oh, I'm getting older, or, oh, I had a knee injury when I was younger, things like that, when in actuality it could be related. And again, that's something that you want to go ahead and address as early on as possible.
Yeah. When I see a patient with psoriasis, that is a pointed question I ask: are you experiencing any joint pain? And then we do a deeper dive. If they do say yes, what joints? And we can kind of tease apart, and we can have a good idea of whether they're experiencing psoriatic arthritis or not.
Yeah, and I think it's really good to let your primary care provider know that you have psoriasis as well, because I think it's so easy for people to kind of categorize the skin into one folder and then every other organ into another folder. And that's kind of why we try to bring the inside and the outside together. And I think, you're at increased risk for other inflammatory conditions too. And like you said, people might feel like they have joint pain, but they may never even think about associating it with the skin. And yeah, there are great treatments for the skin, but a cream is not really going to help your joints.
Yeah. So let's go into treatments then. I mean, there has been an explosion of new treatments for psoriasis. So let's start off with the basics. What do we have in terms of the treatment?
So a lot of topicals that we use for eczema, like our previous episode, we do use for psoriasis. So very commonly, topical corticosteroids. So these are steroids that we can use to help calm down flares. Ideally, you don't want to use them long term because they can thin the skin. But with psoriasis, we often pair them with vitamin D analogs. So for example, calcipotriene, and that's going to make the treatment more effective. They work synergistically better together. That's something that's very different from eczema. We don't often use the calcipotriene with eczema.
Interestingly, we also see a lot of vitamin D deficiency in psoriasis patients. So I often talk about, vitamin D supplementation.
Yeah. There are other more like maintenance creams that we use. So the steroids are great for flares, and then there are non-steroidal anti-inflammatories, and they're tackling different immune pathways to help control the rash and the itch and the inflammation.
Yeah. So we can obviously go into more depth about these medications, but let's dive into some of the more systemic medications that we use for more severe cases. So let's talk about the traditional oral medications, so steroids, right? That was a mainstay of treatment. However, what we see with psoriasis, and we don't really like using steroids because it can cause a huge rebound effect. So even though the patient may temporarily get relief, the inflammation is reduced because the steroids are reducing all inflammation, the minute you come off of it, I have seen the worst rebound effects from that. So it's typically something that I stay away from for most of my psoriasis patients.
Yeah. There are other kind of like old school oral medications.
Outdated.
Yeah. Methotrexate, cyclosporine. I don't know the last time you prescribed methotrexate.
It's been a while,
it's
since residency.
Harsh. You have to do blood work. We used
to use it a lot though.
Yeah. I've definitely seen good success with it, but.
Yeah. And it's one of those medications that did protect the joints, one of the few back in the day. So it was a mainstay of therapy because of that joint protection. But now we have way better medications. Yeah. So let's go into those biologics.
So we have some oral options that can help target those immune pathways. We also have a lot of injectables. So it depends on which class you're using. And there are multiple receptors that are affecting psoriasis. So if we can block certain receptors, we can block that immune dysfunction.
So as we've understood the pathway of psoriasis more, we've identified a lot of different molecules and their receptors in that pathway. And that's been the target for a lot of these pharmaceutical companies. They're trying to find a medication that blocks that to shut down the inflammation, which is much more targeted, less side effects, and overall much better outcomes.
Yeah. Yeah. I think the first one that was on the market was Humira for biologics. We've come a long way. I haven't even ever counted, but we probably have
At least 20.
Yeah, I was going to say 10 to 15, but
Yeah. I mean, they're, like with Humira, the TNF inhibitors, and then now we have specific molecules like IL-17s, IL-23s, IL-12s. I mean, it's really phenomenal what we have to offer our patients. And, there are certain medications now that we're seeing are better for certain types of patients. So we're trying to stratify and understanding like which medications will give the patient the best outcomes and more personalized.
Do you ever think there will be some sort of like test to see
I think there's going to be a test.
which one's best for you?
They do that with like antidepressants. They take they do a saliva swab, and I guess they can see which one would work best for you.
Yeah.
So it's funny, I was having this conversation with a patient the other day, and I think that would be ideal to be able to find that pathway, be able to put them on,
Yeah, as we're getting more data and more tests are developing, I do think that, there's going to be a genetic panel that we'll be able to order. We'll be able to target which medications will work better. And, that'll, contribute to more targeted medicine.
I think the medicines, the biologics, it is so nice that there's so many different ones. A lot of them do have different dosing schedules. So I think it's important working with your provider to make sure that you find one that works with your schedule. Some are more frequent than others. There are some that are every 3 months, some that are every 2 weeks. So I think making sure that you find what works best for you, and then hopefully it physically works for you, and you're able to kind of continue. But there's so many options that you'll find one.
And some of them are better and approved for the psoriatic arthritis and joint involvement. Some are really good for scalp psoriasis. And
some are good for patients who have inflammatory bowel disease.
Yeah.
Some of them are better for, just a variety of other different comorbidities. So I do think that, getting a good history and then, just making sure that, all the checks are, ticked off and, we're able to give our patients the best care possible. Unfortunately, these medications are very expensive. And insurance can be quite a challenge to get these patients coverage, as Courtney can attest to.
Yeah, it's funny because these medications are not medicines that you go to your local CVS or local Walgreens to get. They're a class of specialty drugs, meaning they go to a specialty pharmacy that handles. And most of these biologics, the injectables anyways, do have to be refrigerated. So that's also something to keep in mind. But the nice thing is, even if your insurance doesn't approve, which I think tends to be I think the main question patients ask up front, what is this going to cost me? And it is scary. It's an injectable that you don't know. You've heard that it's so expensive and you don't know how much you might be liable for. But the nice thing is a lot of these companies, these drug companies have put together patient assistance programs where they have copay cards. So maybe, you're only spending $5 or $25 a month, or you get free drug until your insurance approves it, or different ways to make sure that you're getting treated. And I think that's the main thing, is as long as you're getting that medication, don't worry about how, just keep getting it.
Aside from biologics, there are some other treatment options. Phototherapy can be very helpful for psoriasis. I mean, it's a very photoresponsive, disease. We see, some patients just going out in the summertime in the sun and notice their, psoriasis improve, although I'm not a huge fan of that. Some of them go to tanning beds, and I don't really advocate for that, but it is an option for patients who really have no other means sometimes. And there's also an excimer laser that we use to treat psoriasis, obviously for more targeted, localized areas. But it is another option and insurance does cover that for some patients.
Yeah.
All right. So psoriasis is obviously a very complex disease. A lot of people suffer from it, but you don't have to suffer in silence. We have a lot of different options. It's important to make sure that if you do notice that you're having psoriasis, get evaluated by your board certified dermatologist. Also, make sure that you discuss any other symptoms like joint pain, because that can be debilitating, and it can also help us with steering the treatment choice. So psoriasis is something that is extremely challenging to treat sometimes, but we have a lot more options today.
Yeah.
Any other final comments?
Just reiterating that it's not, there's not just one treatment. I think based on you and based on your needs and your type of psoriasis, there are lots of different treatment options.
And from our psoriasis patient.
Personal feedback.
Personal. Now, just again, being, I think, honest and transparent with the symptoms that you're feeling, disclosing some of your medical history. I think those are all pieces of the puzzle that gives insight to your provider. And then I think also, like Dr. Zane mentioned earlier, following through with a rheumatologist, I think can be so important for a lot of patients. And again, really connect the dots and help them feel better more than just skin wise. So.
All right. Well, thanks for listening to this episode on psoriasis. If you have any questions, feedback, comments, please reach out to us. Please follow, share, and like. But until next time, Skinside out.
Thanks for listening. This episode of Skin Side Out is complete. If you enjoyed today's episode, don't forget to subscribe, rate, and leave a review wherever you listen to your podcasts. For more tips, updates, and behind-the-scenes content, be sure to see what fun we're up to on TikTok. Follow us on Instagram and Facebook at Nor Dermatology and Aesthetics. Check us out online at norderm.com. Discover why our patients give us 5 stars on Google. Call us today at 919-617-0717.